I have the privilege of introducing our next speaker, our first speaker of the day, someone I have a lot of respect for. So I'm going to introduce Dr. Anthony Luke. He's going to talk to you guys about the top 5 foot and ankle problems that are seen in primary care. Dr. Luke is a longtime chair of this awesome course. He used to do it, and then he got smart and walked away and gave it to us. So he's done this for a long time. He started this conference over 20 years ago. So he's been doing a good job, and we just keep trying to do good for him, really. He's an amazing clinician, teacher, and a professor in the Department of Orthopaedics. He's the director of the UCSF Human Performance Center and the co-director of our high school outreach program, UCSF PlaySafe. Dr. Luke's clinical expertise include conservative treatment of sports and orthopedic injuries, musculoskeletal ultrasound, and pediatric sports medicine. Dr. Luke is our running medicine and technology innovation expert. In our Human Performance Center, he studies running mechanics. He's studied marathon medicine and has developed an app to help streamline medical coverage at major athletic events across the country. He's a great doctor, great colleague, great mentor to future sports medicine professionals. And fun fact about Dr. Luke, I'm going to give you a fun fact of all of our speakers this morning. He beat Sugar Ray Leonard. I'm just going to leave it at that. That's all you need to know. So please join me in welcoming Dr. Anthony Luke to the stage.
Great. Good morning, everybody. So to qualify that, yes, I did beat Sugar Ray Leonard, if you know who that is. This is way back when I was in high school. He came to Ottawa, which is my hometown, and he and his trainer challenged us to a tennis match. So fortunately, he isn't a tennis player, so we were able to beat him. But he's the fastest human I've ever seen move. Like, very cool. All right, so thank you for coming. It's a pleasure to be your first speaker. We're going to talk a little about foot and ankle problems today. I have some disclosures, as Danny said, in digital health, but it shouldn't affect the talk. So in office, probably the most common things you're going to see is a lot of heel pain, tendinopathies, ankle sprains, stress fractures, and we're going to talk a little bit about bunions today. So let's dive right in. Okay, just a little bit of anatomy refresher. The ankle is kind of got the 2 parts, your tibio-talar joint, which is dorsiflexion, plantarflexion, and then your subtalar joint, which is between the talus and the calcaneus, which is the heel. So that goes inversion, eversion. But when they work together, it's like an angled hinge. So when you just roll your ankle around, it's moving on an angle, not just front and back and in and out. In terms of the foot, just think of the foot as 3 kind of ranges: the hind foot, the midfoot, and then the forefoot. And we're going to talk about the different problems that happen. But the nice thing about the foot is, usually where it hurts is where the problem is. So again, we're going to start in the hind foot. So let's give you a little case to start off. You've got a 25-year-old sprinter. She kind of just starts out of the blocks and just feels like someone hit her in the back of the leg. So she can't finish the race. She stops right away. She's still weight-bearing, but she's limping badly. And when you just say you're on the sideline, you see this, and you look at her feet. There's the right and the left. Okay, so what do you think this is? Is this an Achilles nodule, a gastroc tear, drop foot, Achilles tendon rupture, or stress fracture? So if you got, I think the Hoover app, is that how the answer got? Okay. If you've got your technology, you can pull that out. Otherwise, just kind of think in your mind what you think it is. Waking you up in the morning. All right, most people thought it was the Achilles tendon rupture, and that is correct. Even though they can't move the foot, Achilles is attached to the gastroc. Stress fracture, we'll talk about those in a little bit. All right, so when you have an Achilles tendon rupture, this is one of the most commonly missed things. For those of you who even work in the emergency room, some people don't think about it just because it's not always so traumatic. But when you see it, you may have saw that picture. One foot was plantar flex, the other one was kind of neutral at 90 degrees. It was the one that wasn't plantar flex that is torn because there's no tension on the Achilles tendon. So usually when you feel it, there's a little bit of a gap, and when you do the test, you squeeze the calf, and the foot doesn't move because it's no longer attached. That's called the Thompson test. Now, the imaging that you can do to confirm it, because a lot of times it's a clinical diagnosis, right? They can't put the foot down, you squeeze it, it's not moving, you feel a gap. It should be a spot diagnosis. However, to confirm it, ultrasound and MRI are both really good modalities to be able to test that. In terms of treatment, the big controversy is conservative treatment versus surgical treatment. And conservatively, you can put them into a boot. And over the years, things have changed. We used to non-weight bear people with the rupture. Now they can put them like in a bit of plantar flexion. So they have these special boots. That's something you can purchase for patients. It's around a couple $100. It's called a VacuPed boot. Some people just use your normal walking boot and put a lot of wedges in there, but that's not really designed as well, a little bit uncomfortable. But they're actually even letting people weight bear on this as long as they're immobilized in plantar flexion. So the key is to keep your foot in plantar flexion so the ends are together, so they'll scar back up, and then they'll even let them weight bear. But early on might be nice to give them crutches for a couple of weeks, but once they start weight bearing okay, we keep them in there for almost 8 weeks, and slowly as they get better, drop their heel down so they're not stuck in like plantar flexion, get too tight. And they'll start doing rehab as early as 3 weeks. So things have changed a little bit in the conservative treatment of Achilles tendon ruptures. In terms of the opposite though, like obviously there's the surgical options. And the big trade-off is really your risk of infection, because if you operate, there's around a 11 to 13% chance that people could get an infection or skin sloughing. It could be a problem, whereas you don't operate, that's not gonna happen. However, when you do sew it together, there's less chance of re-rupture. So that's really the trade-off. Do you want to trade infection versus re-rupture? So for high-level athletes, they're probably still leaning toward operating on this because they're going to have a stronger Achilles and get back to their sports. On the left, you're going to see a night splint. Remember, we got to keep them in plantar flexion. Imagine if you had to sleep in that giant boot all the time. So you can get these things. Again, you can buy all these braces even on Amazon nowadays. It's just a reverse night splint. This is what someone looks like conservatively, one of our basketball players. If you take a look on the top right corner, you can see the Achilles is really thin, and on the right, it's really thick. It was the right side that was the one that was treated conservatively, and it's really flexible. They get more motion because it doesn't heal as tight. So it's more difficult to jump or create power. But it does work, like randomized controlled trials, conservative versus surgical, people are doing very well. So some countries, they don't even operate on them as first line. All right, so keeping on the back of the Achilles, the more common thing is gonna be just tendonitis, or what we call tendinopathy. Just say you're a normal runner who's doing a lot of plantar flexion and stuff like that, they just get soreness in there. And if you've seen someone with chronic Achilles tendinopathy, they might even develop a nodule. You feel over the Achilles and there's a big bump of scar tissue that's inside the Achilles. And that's usually becomes painful because there's micro tears and scar tissue happening there. Some of the risk factors for Achilles tendinopathy, they're kind of the things you would think of. If you've got this tight Achilles band and it's repetitively being used, if you've got a really tight calf or Achilles, that might be a problem. If they have foot problems, like maybe their foot is too flat or it's too high, those things might be risk factors. Of course, how much load it needs to be. If someone's heavier, that's gonna be a problem. And then bad footwear. But they've even found things like weakness at the hips and knees. You're gonna hear a lot of really good talks by our physical therapists talking about how important we gotta get core work and things like that. Sometimes even problems higher up in the body can affect the Achilles. Now, some other things, if you're in the primary care setting, you gotta think about what medications there are. Oral steroids, if they're on it chronically, could be a problem, especially in your older patients. It's not really a problem for your younger patients that have healthy Achilles tendons, but definitely in your older patients, 50 and up, that have chronic disease. Fluoroquinolone use is a risk factor for Achilles tendon ruptures or ruptures of all tendons. And then you can see some of the endocrinology things, like, again, chronic problems, diabetes, hyperparathyroidism. And then on the ones on the right, those are, again, activity-related stuff. So if people have had long-standing Achilles problems, unfortunately, they're likely to continue to have problems. So think about those kind of risk factors in terms of when you're seeing somebody and they keep having problems over problems again and again, think about some other things that might be predisposing them to this. Now, in terms of the therapy, we're doing the stretching. So again, if someone's too tight, we want to stretch them. Similar concepts you're going to hear. If they're really flexible, then you want to strengthen them. So we do the calf stretches. And remember, there's two muscles back there, the gastrocnemius and the soleus. So you have to do the leg straight as well as the leg bent for their stretches. And you want to hold stretches for around 30 seconds. Another good program to really strengthen it and stretch it is these drop programs. So people do them off a step. So you're really kind of like an athlete would, like kind of really stretch it with their full body weight and then explode up. And that's what you want to retrain the tendon with. So a lot of times in therapy, they're going to teach them these exercises off a step. Now, some of the more recent literature, JAMA had a really nice article if you just want to read about foot and ankle. That's by Cooper. They talk about a lot of the different foot and ankle problems. But they found that those eccentric exercises work and they give temporary relief. Topical diclofenac, you're probably going to hear that in many of the talks now. We're using that a lot of times first line for problems because they're low risk but could help. The night splints, you probably heard about people going like kind of stretching the foot all night. If you've tried it, it's super uncomfortable. Most people get rid of them halfway through the night, but you are stretching them. You might have heard of shockwave. There is positive things about using shockwave. It's like lithotripsy we used to use for kidney stones, but you have to find someone who has that. Anti-inflammatory is definitely for short-term relief. Now, PRP is like, we're going to have a talk on orthobiologics later, but that's something that has some positive results on that, so you might hear about people using that. And then surgery for Achilles tendonitis, not a lot of data, but very rare to be done. Okay, well, let's talk about another kind of heel pain problem. So you got a 48-year-old tennis player. He's got heel pain for 3 months. He can't even play his sports. He gets up in the morning, he's really sore. The first 20 minutes of walking around is already very sore. You probably heard this a few times in your office. But he's had a similar episode a year ago, but that went away in 2 weeks. So this one's worse. So what's the next best step for this patient? Partial weight bear them with crutches, send them for an x-ray of the foot, rest for 2 weeks, no sports, eccentric calf exercises, or send to orthopedics. Sure. It's just heel pain for 3 months, and they can't play sports. So they're still able to get to work, but it's right on the bottom of the heel. All right, all right, so some people want to send for an x-ray of the foot. Some people want to rest, and some people want to do the eccentric calf exercises. I think definitely the rest or the eccentric calf exercise would be what I would choose, because this is a case of plantar fasciitis. How many people have plantar fasciitis in the room? All right, so listen close. All right, so what you're looking at is like tenderness on the insertion of the medial calcaneus, or you think you guys can play that video? I think you have to kind of hover over the play button on that. So it's kind of right over the medial heel. There's one spot that you can see the band of the plantar fascia, but right down near the bottom, right on that spot, it'll be like a button. It's always on the inside part of the heel, and they'll light them up. The risk factors, pretty similar to what we talked about with the Achilles, and the longer they have it, the longer it's gonna take to go away. Like, if it's only been a couple of weeks, yeah, you can rest them, tell them it's gonna be okay. If it's been around 3 months, might be something they gotta really kind of take a break from their sports and get into some therapy. You can do an x-ray, but the x-ray is often going to be negative, or they might have that little heel spur, right? You often get that on your reports. If you have a heel spur, it doesn't mean you have plantar fasciitis, but if you have plantar fasciitis, you're more likely to have a heel spur. So again, just the x-ray is usually non-diagnostic. If in bad cases, people might need an MRI if they're really not getting better after therapy and stuff like that. You can have little tears of the plantar fascia right as it goes in, and that just means it's going to be a little bit harder to treat. In terms of the treatment program, just like we talked about for the Achilles, we're going to do a stretching, strengthening program because the two of them work together to make you go on your toes and push off while walking. You might want to protect them. There's these Thule heel cups that are really comfortable, and that really makes a difference for them walking around, not as painful. Some people, if they do have really flat feet or something, orthotics, over-the-counter or custom could be helpful. And then for athletes, sometimes we'll tape their arch and things like that to protect their plantar fascia. If they're getting kind of worse, definitely physical therapy would be in order. The night splints, we talked about stretching them at night. And then we can maybe sometimes even do an injection of steroid or platelet-rich plasma. And then finally, surgery is the last resort. Again, very rare that someone has to go to surgery for plantar fasciitis, but if they're not getting better after 3 to 6 months of pretty good treatment and they're horrible, they can't walk, then, referring them to your podiatrist or foot and ankle surgeon is appropriate. So in terms of an injection, this is that plantar fascia, and the inside is on the right side. When I do an injection, for those of you who do injections, I kind of come in along the plantar fascia on the inside border and want to end up right at the medial tubercle. So that way, as I I go right down to the medial tubercle, and then, because sometimes they're a little bit inflamed along the plantar fascia too, so I can leave a little injection and steroid along that. But you really got to get right down to the bone. Okay. Case number 2, we got a 53-year-old female, and if you take a look at her feet, one side's more pronated than the other. You look at that right side, you see how her right heel's kind of angled outwards, and you kind of see the outside of her foot. She's been having medial pain around the ankle for around 4 months, and then all of a sudden her arch started to collapse. And she's having difficulty pushing off. So what is your diagnosis? So pes planus or flat feet, posterior tibialis dysfunction, drop foot, Lisfranc sprain, or an L5-S1 radiculopathy. Let's see what you think here. All right, so a little bit of everybody. Number 2 was correct, posterior tibialis dysfunction. So let's talk a little bit about that. So just a word about tendinopathy, because we always call it tendinitis, right? Tendinitis is acute inflammation, but a lot of the chronic things are more tendinosis. Over time, you get micro tears of the tendon, you get scar tissue, and the thing actually gets degenerative. That's why it's really hard to heal chronic tendinopathies, because you almost look at that picture on the left, that's the nice fibers of collagen, and if you injure the area too much, it just scars up. Remember we talked about the Achilles nodule? You think you get a lot of scar tissue, it starts building up. And that just doesn't work very well for tendons. And so for the posterior tibialis, that's the muscles running on the inside part of the tibia. It's right behind the bone, and then it wraps around to the bottom of the foot. And we're going to show you during the exam how you look for this. But it's really important for keeping the arch up. So over time, it's usually an older patient, 40s to 50s, they just get chronic strain on this tendon, and then the thing fails. It stretches out, and then your arch starts to collapse. And then it's really hard to get that back because it's a small tendon. So I'm examining it. It's usually very painful right as it wraps around that medial malleolus, but it sometimes goes right on the navicular bone. And then, so sometimes when you invert and stretch it, and then they try to push their foot inward, that's when it hurts. And I'll highlight it again when we do the video of how the exam goes. But just think about it. It's usually, again, your older patient. Maybe they're a little heavier. Women do get it more than men. and then they kind of report sometimes a sudden collapse of their arch. So just be on the lookout for that. Now, treatment's kind of brutal. We've got to really get that tendon to heal. And just like we did for the Achilles, we're going to actually immobilize this posterior tibialis tendon and hope that it tightens up. And this is an example of an ankle foot orthosis. So they'll actually mold the arch, make sure that it stays kind of set. And then you got to immobilize it for a good 4 to 6 weeks. And this is one of the ones that maybe you want to send early to your foot and ankle surgeon or podiatrist to take a look at it. Because sometimes they might intervene, because these ones are hard to heal, and sometimes they'll go for a surgery early to kind of reinforce that tendon. They might even transfer tendons down, because if you don't have this tendon, it's really hard to walk. So, you can try conservative, especially if they still have good power, but if they can't even go on their tippy toes, you might want to send that earlier. If you do treat it conservatively, obviously as they get better, we got to do a lot of physical therapy, and then we go. Okay, case 3. Yeah, everyone loves this one. We'll just play it a few times for you. All right, but that's what happens with an ankle sprain. When you even had your ankle sprain, you might have looked like that. Sometimes it's pretty bad, right? So what is the most common acute injury seen in your primary care office? Patellofemoral pain, sciatica, Achilles rupture, anterior talofibular ligament sprain, or stress fracture of the third metatarsal. All right, so the anterior talofibular ligament sprain, that's your normal ankle sprain, and that's what it was. I thought the video would give it away, but that's all right. It's early in the morning. More coffee. All right, so ankle sprains are one of the most common acute problems that we're gonna see. This is what the ankle might look like, a lot of bruising, sometimes a little bruising around the heel just because the blood kind of settles down there. And just remember, like a lot of these ankle sprains are recurrent, right? Once you sprain it once, it's very easy to have it sprain over and over. Now, we're gonna go over these tests, but there's 2 key ligaments, well, there's 3 ligaments on the outside part of your ankle. The anterior talofibular ligament runs forwards so that when you're actually plantar flex, that's the one that goes first. It's like your foot is tipped, and then that's the ligament that goes. But when we test it, we're just gonna see how much it slides forward. I'm gonna show you that with the next session. And then the tilt test, you just keep the foot in neutral and you see how much it opens, because the calcaneofibular ligament runs vertically. So then you wanna see how much inversion they have on their foot. And these 2 tests are really nice to master. That's an example of an abnormal tilt test. You can see the one on the right ankle is really tipping a lot more than their left ankle. And it's nice because this is how we kind of use the physical exam to grade your ankle sprains. You're really looking at which ligaments are hurt. Because as you sprain your ankle when your foot's usually plantar flexed, and then it turns, usually hurts the anterior talofibular ligament first, and then the calcaneofibular ligament next. So then if they have a positive drawer test and a positive tilt test, then that's a pretty bad ankle sprain. That's almost a grade 3 sprain, and they're probably gonna take several weeks to recover, like almost 12 weeks. But if they are really tight and they just are a little bit sore and there's not that much swelling, then they're probably a grade 1. Those are the ones you can kind of say, it's gonna probably take a couple of weeks, just rest it, ice it, and then you'll probably be ready to go in a couple weeks. Okay, so acutely, for an acute injury, like most things, there's different mnemonics that are going out there. Mice is a pretty simple one, like modify their activities, ice, compression, elevation. If they're really uncomfortable, give them crutches, anti-inflammatories. These are the kind of similar things you're gonna use on many musculoskeletal issues in the lower extremity. But we do wanna move an ankle sprain early, so physical therapy is gonna be really important. Now, this is just a slide about ligament healing. So what's going on is on the vertical, it's person's pain level, and on the horizontal, it's actually how many weeks it's been. And the curve on the right is the pain. So the pain's usually kind of getting better after around 2 to 3 weeks, right? And then the ligament's actually healing, and it's usually taking around 6 weeks to tighten up. So it's always around that period, that 2 to 3 week mark, that people start to kind of go back to their sports, right? And that's when they're most vulnerable to get re-injured. And just remember that scar tissue just isn't as strong as the original tissue, so that's why they sprain a lot. Excuse me. So in terms of getting them better, rehab, so important. You want to improve their range of motion, get their strength back, then get their function back, and then the sports stuff comes along. So it's always in that sequence that we're rehabbing people before they get back to play. All right. So for some more advanced kind of concepts, to get somebody back to an ankle sprain, balance and proprioception is really important. They've really got to feel and control their ankle. So one thing that's important, you have to have the right range of motion in your ankle. So one way you need to know if their ankle goes high enough, because sometimes they're stiff, they're in that plantar flexion position, very easy to turn again. So a way to kind of measure that is kind of to lean forward and see how much that foot is going. The other thing is to do dynamic testing. So you can do this in the office. Can they hop? Can they stand on one foot? And there's a special kind of test called the star excursion test. It's something that's very easy to set up, but you just test their balance, moving their other limb in other directions, see if they can balance on that. So this is what we'll do on a kind of athletes to get them and see if they're ready to get back to sports. Now, ankle braces can be really helpful for your patient, just getting them into something to secure them during the acute period. The air cast is the one that you see on the bottom right. It's pretty secure. You see that a lot in patients after they go to the emergency room. The ASO brace is a more functional base, and people can play sports in that, so it can simulate a tape job. But taping is another option for people, but it does reduce recurrent ankle sprains by almost 50%. So for your athlete who's either acute or has had multiple ankle sprains, playing in a brace can help them for most sports. Now, I'm not going to go through all of these, but just remember, if your patient's not getting better and it just sounds like an ankle sprain, there's a lot of other associated injuries that can happen, all the way to injuries on the talar dome, like the cartilage, or other bones get fractured and you can't see it on x-ray. So just remember, if they're not getting better, like 3 months after an ankle sprain, that's a long time. If they're not getting better, you might want to look for occult injuries. And that's where an MRI might help. Now, I'm just going to highlight high ankle sprains because this is one of those problems not to miss. So it sounds like an ankle sprain. Maybe something happened to their ankle, but maybe they didn't turn in. Maybe the foot got turned out, and the pain isn't in the classic spot in the anterior talofibular ligament area. It's kind of higher and up around the tibia and the fibula, like higher up around the top of the ankle joint. So that's where they have pain. And this is where the syndesmosis is. So the mechanism of injury is actually when you turn your foot out, and I'll show you when we do the exam how you do that. But a lot of times to test it, you just want to externally rotate their foot, like push their foot out. So the opposite of what you think an ankle sprain would be. And they hurt high up in the ankle. Another thing is if you squeeze the tibia and the fibula together, they might have pain down at the ankle because you're moving the bones and it's a little unstable. This is really important because what happens is the tibio-fibular ligaments up high, they keep the bones together, but when the injury happens, it actually splits the bones apart so that they're a little bit unstable between the two bones. And so remember we were saying you want to move an ankle sprain early? On these ones, you want to protect them. You don't want them walking on this one because that'll just kind of keep the ankle being loose. This one, you want to put them in a cast or a walking boot and get them off with crutches. So it's one of those things not to miss if you're suspecting this, because some of them will go all the way to get surgery, like you see the screw across. In some athletes, they'll just elect to fix it for them. All right. Case number 4, we got a 17-year-old basketball player, and she kind of had pain over the lateral ankle. Like she does sprain her ankle from time to time, but she doesn't remember if that's what did it. And but she does remember after a rebound landing, and then she got pain over the lateral foot. And then she's been having pain, and she's having difficulty walking for 4 weeks. And you finally get an X-ray, and this is what it looks like. There's a fracture down at that base of the 5th metatarsal. Okay, so what is your diagnosis? A metatarsal shaft stress fracture, a Salter fracture type 3, a 5th metatarsal avulsion fracture, a Jones fracture, or a cuboid fracture. So this is like a hard orthopedic one. You have to recognize some of these terms, but making them harder and harder for you. Okay, let's see what you think of this one. Okay, so most people was correct. It was a Jones fracture. So let's explain what all these kind of fractures are. Okay, so here's like the base of the 5th metatarsal is one of the most common areas to get an injury, because like we said, ankle sprains is the most common thing. And usually what happens, you just get an avulsion fracture right at the tip of the 5th metatarsal. So that's in that blue area. You just pull off a chunk because your peroneal tendon inserts right there. And then so you treat that one like an ankle sprain. However, the worrisome one's that red area. That was the one that you saw from that X-ray. It's kind of just right at the metaphysis of the bone where it starts to flare inwards. That's a stress fracture. And that has a bad blood vessel right in that location. And so it's really hard to heal that one. So we don't want to miss that fracture, because if you just leave it, it can go on to not heal at a high rate. So in those kind of cases, like just say it was a basketball player and she's competitive, sometimes they'll have to go all the way to put a screw into that foot when it's in that location. So the location on the X-ray is very important. If it's just a little fragment at the tip, you can treat that like an ankle sprain, especially if it's not very displaced. But if you see it in that metaphysis area, that's one of the ones that you got to get them non-weight bearing, and then maybe visit your foot and ankle surgeon. So that's an example of the base of the 5th metatarsal. That's going to be the most common fracture you're going to see in the foot. That goes along with your ankle sprain. Now, metatarsal stress fractures, like where you normally see it, like if you take a look on that X-ray, you just look at each of the rays. You might think to yourself, which one's the one with the stress fracture? It's actually the second, yeah. The second long bone. You see how like there's this periosteal reaction? That bone is trying to heal. So you won't see that within the first 10 days, but after a couple of months, you're gonna see it, and they'll be really painful right in that location. And the graph on the left is just college athletes and how long it took them to get better. And it's 1, 2, 3, 4 by the grading system on MRI. So if you have a bad stress fracture, sometimes it's almost like 16 weeks for a stress fracture to heal up. So I kind of recommend that if you find a stress fracture, just give them the long term. It's probably gonna be 12 to 16 weeks to get better. Because if they get better, you're gonna look great. They got better early and they can go back to their sport. But if you underestimate it, tell them it's 6 to 8 weeks and it goes longer, they're gonna get upset. So just give them, if you think it's a stress fracture, give them the longer term. And because sometimes it does take that long. And that's where the stress fracture is. And just remember for our young female athletes, again, if they have any disordered eating or anything like that, they're higher chance of getting stress fractures. So think about that in your cross-country runners and dancers and things like that. Okay, last case, and then we'll get on to the exam. You got a 64-year-old female who's got pain around the big toe, where you've got that big bunion. You've got that X-rays with all those angles on them. So what is not a criteria for a bunion? An intermetatarsal angle of 13, that's kind of between the first and the second ray, bigger than 13 degrees. lateral subluxation of the sesamoid, clawing of the toe, a wide forefoot bigger than 120% of the midfoot, or a first metatarsal phalangeal angle of 20 degrees. Again, testing your ortho stuff. Which one's not a criteria? Clawing of the toes, yes, but it's actually the wide 120% of the midfoot. I made that one up. Because actually you have a bunion over time, they will start to claw at the toes, but there's no thing about how wide your foot is in the middle versus the top. So I made that one up. But the other ones are important. So like when you think about it, when you have the bunion, the toes will have a big gap. And the most common one is people look at the big toe, right? The 20 degrees. When you start measuring the shaft and the toes bending off 20 degrees or more, that's where it's starting to get to that tipping point where the toe starts curling underneath the other toe. And so if it starts getting symptomatic, that's when you start letting people take a look at it. Oh, got some email going on. All right, so again, it's just some facts about bunions. It's often genetic, so they didn't do anything wrong. You know, they always ask, why is this happening to me? Just look at your parents' feet and you'll know why. But it's pretty common. Even young people can get it. A third of people can get it even in their teenage years. Oftentimes they're a little more flexible and they have a little more pronation. And then we talked about the rays being a little bit wider there. But often over time, if people wear footwear that's very narrow, they're going to develop it. That's why women get it a little more than men. And then it gets pretty painful. When it gets to the wrong ankle, the big toe is just so important for walking. And then you start getting some arthritis in there, and then it gets swollen. So it gets to be a big problem for a lot of people if they can't walk. And then don't forget that it's also rotational. As the bones are kind of to bend, they're rotating, and you've got those little sesamoid bones underneath. And as they're rolling around, sometimes people get a lot of pain around the sesamoids underneath because the bone's twisting. So once it starts getting like the anatomy's really getting distorted, that's where the surgeons have to start looking at, do we need to correct this? Otherwise, it's going to be pretty painful for them. So non-operatively, a lot of shoe modifications. Make sure they wear more open-toe shoes, not narrowed high heels, that kind of thing. A toe spacer can be pretty helpful. It's a little Silipost pad that you put between the first and second toes to straighten up the first toe. Orthotics, if they're really flat-footed, you can do some bunion sleeves that stop it from rubbing against the shoe and things like that. And again, just check out Amazon, just put bunion, you'll see like 50 products come up. Just tell them to pick. And then on the surgical side though, that once it starts getting pretty painful and the angle's kind of clearly increasing, that's where you probably want to send them to your foot and ankle surgeon. And there's many ways to fix a bunion, but they're not always great solutions. They don't always work, so they're a little bit challenging. Results vary, but they're 70 to 85%, and it takes a while for them to heal. So it's not a fun thing. All right, so with that, we're gonna move on to the exam portion. If you do have questions, put them in the Whova app, because we're gonna have some Q&A right after the session. And I think I'm gonna get some assistants coming up here, and we're gonna show you live video demonstration. And maybe we'll switch to the other slides, guys. You're my model? Okay. Hallie is our model today. Awesome. Thanks for coming over. Great, great, great. Awesome. Cool. So when you look at the slides, I like looking at all my peripheral joints and look, feel, move special tests. So we're gonna start with the ankle, and then we'll move on to things of the foot. The foot's a little easier because, like I said, most of the time where they have pain is where you gotta look. unless it's some referred pain, like a nerve or something like that. But let's take a look here. So a lot of times, one of the first thing I'm gonna do is watch her walk. So if I get you to come back up, Hallie, you're gonna kind of just, I don't know if it's easy to zoom back down. But it's just really important to see, does the foot move and how it pronates and stuff like that. And then obviously you can see if she's having pain and stuff like that. So that's not too bad. You kind of see as she kind of comes in, and maybe go back one more time, you're gonna see that her middle of the arch does roll a little bit, and that's what we call pronation. Now pronation isn't always bad. It's important that we can hit uneven ground and adapt to it. But sometimes, like if it's associated with pain or it's very excessive, you can see how it pulls on the Achilles and the plantar fascia and all that kind of stuff, and that having a more stable arch would be beneficial. Now, another thing I like to do is maybe if you've turned toward the camera there, you're gonna just go on your tippy toes. So in that way, you can kind of see how high her arch gets, and you see how flexible her feet are. And then as she comes down, you can kind of see how her foot adapts to the ground and what happens. So maybe we'll do it a little bit faster. We'll go up, and then we'll come down. And then you just want to see how the midfoot. So she does maintain a bit of an arch, but when she walks dynamically, she does get a bit of a rolling activity. Now, another thing I like to do is maybe have her do 10 heel raises, because you see how strong her muscles are. And if she ever has weakness on one side, you got to think all the way up to maybe is she even weak on someone with sciatica, an L5-S1 nerve root, right? If they have weakness on the calf. But that gives you a good sense of the general ankle strength and foot muscle intrinsics, or is this a problem? If she can't do that, walking's gonna be a bit of a problem, right? Okay, so let's start like here, because you're gonna be up here. So look, feel, move special tests. So now where do I look? So if she just had an ankle sprain, we said that's one of the most common things, she'd probably have swelling kind of right in this location, right in front of the medial malleolus here. And then so look, and then other areas, like if she had kind of some irritation around the tendons, they might have a little fullness over the medial malleolus. That's where you look for the posterior tibialis tendons. If I'm looking for the Achilles, a lot of times I'll lie her down on the table. And then, even sometimes the foot, you want to look at both sides. Sometimes those stress fractures, you're just going to see that they're a little bit swollen or puffy in the top of the foot or something like that. So that might tip you off. Bunions and things like that, obviously you can look at the angle of the big toe and stuff like that. That should be pretty clear just on the normal anatomy. So look, feel. So feel is important. Remember we did the ankle sprain example. There's this thing called the Ottawa ankle rules. That one's really important for looking for fractures. So what we're gonna start with is I'm gonna feel over the fibula and the back portion of the last 10 centimeters. Because if you're gonna have an ankle fracture, the fibula is one of the most common ones to be injured. And then the other thing is you feel on the inside. So I'll just show you on this side. You just run your finger on that and you feel the tibia. So those are what you check for the bones of the ankle. And then for the fractures of the foot, we talked about the base of the fifth, right? So I'm gonna feel right at the bottom of the fifth metatarsal and then see if she's tender there. And then the other spot is the navicular bone. Like on Hallie, she's got a very prominent one, and that's not uncommon. Some people even have an extra bone here. So you just feel right on that, because that's where the posterior tib goes in, but it's also the most common spot to fracture. Because when she crunches like this, she does an ankle sprain. Remember, the ankle sprain turns inward. It can sometimes crunch the navicular bone and you can get a fracture. And that's why you have those Ottawa ankle rules. So you feel the last 10 centimeters of the tibia and the fibula, and you feel the base of the fifth, and you feel the navicular bone. And then if you have pain in the foot, you get an x-ray of the foot. And if they have tenderness here, then you gotta get an x-ray of the ankle. And so that's been pretty consistent. Like if they have no pain in any of those locations, then you usually don't need an x-ray after a sprain. Okay, so of course there's other areas that we have to feel, like just say she's a sprain, she's most definitely gonna be tender in the anterior talofibular ligament area. So that runs from the fibula to the talus. So it's almost like this line here. And then, again, that's the most common spot she's going to be sore. Now, the calcaneofibular ligament runs vertically like this. And so you want to feel, and you might, sometimes you can actually feel the thickening of the ligament right there. And that's where that ligament's going to be. And then the last one's the posterior talofibular ligament. That's going to run backwards. If they're kind of damaged all three, it's going to be almost like an ankle dislocation. Kind of, you saw that tennis player really turn and the foot went all over the place. Like, surprisingly, some of those, they never tear all three. But most of the time it's these two in the front, because you'd have to be pretty traumatic to get everything. But that was a pretty bad ankle sprain that you saw on that video. Okay, so look, feel. Now, obviously, we talked about many other conditions. If they have pain of the metatarsals, then you'd feel on those metatarsals. You might find that point tenderness, like here's her second ray. If you remember that x-ray, you'd just be pushing right down on that bone, and it'll be point tender. And that's the difference between like a stress fracture versus like stress injuries. Stress injuries might be very diffuse, but like stress fractures, like you just touch that area and it's pinpoint. And it's pretty painful if you've ever had one. Okay, just remember there's a lot of other structures though. There is a big deltoid ligament there, but that's very strong. It's not usually gonna be bothered. So let's talk about some tendons that you can feel. Remember the posterior tibialis tendon? It's running right down here. It inserts high up here, so almost on the proximal third, and then it comes all the way down, but usually where it has problems on the tendon is right where it goes around the medial malleolus. So you'll be able to even feel it on yourself. There's a ropey structure right behind the bone. If you want to grab your ankle and start feeling your ankle, that's okay. Everyone can do it. But that's where it's tender, but it might go all the way down to the navicular bone right there. So that's what you're feeling on that side. Now, if you're thinking you've got the peroneal tendons, there's another set that everts her foot. That's eversion like that. And they run down like this. The peroneus brevis goes to the base of the fifth metatarsal, right? Metatarsal, which is why you have that avulsion fracture. And the other one goes all the way down and goes to the first metatarsal. And that's the peroneus longus. So there's two of them back there, and you can kind of feel it. Same idea, you'll feel right around the lateral malleolus, and they'll be a little bit tender like that. So that's important because some people get what we call subluxation. After they've tried to after they've had a sprain, sometimes the tendon contracts so forcibly that it strains the retinaculum, which is the tissue that keeps the tendon behind the lateral malleolus, and it'll start popping in front of the ankle. So when they try to evert their foot, it clicks, and they never notice that until they sprain their ankle. And sometimes that's what we call a subluxing peroneal tendon. Okay, we're zooming in here. Awesome. Now you can see it. Beautiful. Look at that nail job. Beautiful. All right. Okay, so this is all like, I'm talking a long time, but this all goes very fast, right? You're already thinking about what your diagnosis is. You're looking to confirm. You don't have to feel every tendon in the foot. You're just looking for the money things. So now we're going to look, feel, move. And now, so movement, we got dorsiflexion. I want to see how high she is. Now, she's doing it actively. I can also do it passively and see how much. So she's getting maybe like a 10-degree dorsiflexion, and that's pretty normal. 10 to 15 degrees, pretty normal. Plantar flexion, I do the tibia, and I look at the base of the fifth metatarsal here. So she's kind of getting to maybe like 60 degrees of plantar flexion. And that's kind of normal. Like a dancer could almost get 80 degrees. If they can't get, like some people, they can only go 20, 30 degrees, and they might be tight on their calf or something like that. They can't go down. Okay, now we talked about inversion, eversion. I want to see, can she push in and out? Those are the other motions. So sometimes I tell them just turn your foot in and then put your foot the other way. And that's inversion, eversion. Remember the angled hinge we talked about? Those are the important motions that you're looking for. Cool. Okay, so that's look, feel, move. Now we go to the special tests. So we'll talk about the ankle sprain things. And just before I go in there, of course, if you think it's neuro, then you want to check your nerves, like into the outside part of the foot, that's S1. In the web space is L5, and the inside of the foot is L4, if you're thinking about dermatomes. And then you want to do your strength testing, like your plantar flexion, you can step on the gas, and then toes toward your head, and then eversion and inversion. Those are the ankle strength exercises. But remember, I got her to go on her tippy toes, right? I got her to do it 10 times. If she can do that, she's probably okay, unless I think there's a muscle tear or something like that. Okay, so let's talk about the special tests. So ankle sprains. I'm holding her tibia to keep her. I want to kind of have her as relaxed as possible. I don't want her to have her like keep her foot up for me, because this way she's nice and loose and relaxed. So I'm holding the tibia, and with my other hand, I wrap my fingers around the heel, and I kind of lift her into neutral, because you don't want to test when she's down here, because the bones will bump up against each other. You got to get her relaxed into neutral, and then I'm just pulling forward. And I'm pulling like maybe around 10 to 15 pounds, like if you're grabbing a barbell and you're just bringing it toward yourself. That's how much you want to apply for your stress tests. And then if someone has a pretty good ankle, it'll just stop. You're going to have a little natural give, maybe like 3 millimeters or so, but it'll just stop. And then for the tilt test, I kind of keep her like in the same position. This time I grab at the heel, keep her in neutral, and this time I'm tipping inward. And it's normal to go in around 10, 20 degrees. But if you got a 10-degree increase on one side versus the other, then you start thinking, wow, it might be looser on the other side. Cool. So again, here's the drawer test again. You're pulling forward. And I don't know if the shadow, you can see a little bit of give, but then a little bit of tipping there. And then you can check the other side. Same kind of thing. Sometimes I use my opposite hands, but you could do it the other way if you're more comfortable with your right. And then the tipping like that. That's okay, I think it'll be all right. Yeah, no problem. Okay, so remember we had other stress tests where you can categorize some of our tests as provocative, and then we could do stress tests for instability. So we'll stay on the stress test because I'm checking her ligaments. Remember we talked about the high ankle sprain? So this is where the anterior tibiofibular ligament is. This is where the anterior tibiofibular ligament is, higher up. So above the ankle joint. So she's bending from here, it's literally right above it. So you gotta feel right on that, and that's where she's maximally sore. And sometimes the swelling's up here, it's not down here where you normally sprain your ankle. So that's a good tip off, and then usually they're walking in, they're hobbling pretty bad, because the high ankle sprain is really painful. So in this case, the mechanism is external rotation and dorsiflexion. So you're kind of bringing the foot out that way. So external rotation stress test. And if you can do it pretty hard and they don't have pain, then that's a pretty negative test. So don't do it really hard if you're really thinking about it the first time. That'll be really painful. The other way is, again, we talked about the squeeze test. We can sometimes squeeze the two bones together, and then she'll have pain down here. Because just motion between the fibula and the tibia, it's so unstable, it gives her pain right down below. All right, so those are those tests. Let me think through. External rotation stress test. Those are the ligament ones. The posterior tibialis dysfunction, remember we got her on her tippy toes. She would have had a lot of problems with that one. If someone has that dysfunction, that would be a pretty easy one to pick up. Let's talk a little bit about some neuromas and stuff like that in the foot. Now, neuromas kind of are when the digital nerves between the metatarsal heads, they get irritated and they actually swell a little bit. So when they actually get compressed, people get an electric shock pain that goes toward the toes. And so if you hear that story, it's like, I get this really sharp pain. It hurts in the middle of my foot, but then it goes to my toes. Just kind of feel in the web spaces. Now, usually the most common is the second and third but the third and the fourth can do it as well. So when you push, like what I'm doing is I'm kind of pinching my fingers like on the bottom and the top. So that's one way to compress it, and that might cause some sensitivity. So you're not feeling on the bone, you're feeling in between, and that'll do it. And then the other thing is you do a Mulder sign, and you squeeze all the rays together, and that'll cause the pain, because you're squishing them, and they irritate the nerve, and then you get that lancinating pain. One other thing just to kind of comment on, like the bunion will just be painful over the bunion, usually on the medial side. They usually get some calluses and weird stuff there. But sometimes people can get a second metatarsal head overload, especially if they have a longer second toe. They rely on the toe, and you might see a big callus on the second toe. They sometimes have a little more pressure there. So feeling over that joint, sometimes that's a common spot that people will be sore on the foot. And then what you do there is you give them a metatarsal pad so they're not walking right on the top. How are we doing, Danny? All right. So that's kind of some of the skills. We're going to go over some of these if you come to the hands-on workshop. So thank you, Hallie. I appreciate it. All right. So I think we have a little bit of time for Q&A before we move to our next joints.
Anybody have any questions?
Classically, we put people in a clinic or ER in some kind of brace with an ankle sprain. More recently, I've been hearing rumors that maybe bracing isn't good, and if it's not a severe sprain, we really should be trying to walk on it a little bit. Don't put them in a splint. What's your opinion on that?
So yes, so if you mean by a splint like a non-weight-bearing splint, like a posterior slab, yeah, I think if you think it's just an ankle sprain, then yeah, using something like an air cast might be the good thing, or even a walking boot. It's easier on your cast techs and stuff like that. Just put them in that, because it might take 4 to 6 weeks to get into your family medicine doctor, and that might be too long to have them immobilized. So I agree with that.
For the Thompson test, is there positioning that's especially sensitive
Yeah.
to that Achilles tendon?
Yeah, sorry, I forgot that one. Yeah, so basically she's just lying right down on her stomach. So you head down that way, and literally her feet dangling off the table like that, and I'm just squeezing like that. Yeah, you don't want them lying with their feet on the table because it's just lying there. You're just gonna have them dangling. And it should be a spot diagnosis. You look at those Achilles there, and then there's a gap. And you can kind of see how her foot plantar flexes there. You can see her foot moves a little bit. Cool, good question. Oh, there's one right behind you. Thanks, Hallie.
So when you were examining her foot, when she was just standing and her arch wasn't fully collapsing to the ground, would she be somebody you recommend just get some arch support on insoles? I tend to encourage that in a lot of my patients because they're on their feet all day.
Yeah, I think you hear a lot of varying camps about orthotics and do you need them or not. If you have no pain and you have a little bit of flat foot and they're not bothered at all, yeah, they don't necessarily need it, right? But if I said, well, it feels more comfortable when I have orthotics in my shoes, what's better? Do you want to buy comfortable shoes or uncomfortable shoes? Now, I think when you think oh, you need orthotics and you can't go without them. I think that kind of concept doesn't make sense. People are going to go Hawaii, they're going to walk around in flip-flops. They're not doing this all the time. So people that, a lot of times you just see a flat foot and everyone's going, oh, you need custom orthotics. I don't agree with that. You don't really always need customs. And sometimes $30 to $40 with an over-the-counter arch support, you get a good sense, hey, this is helping them, but they're still uncomfortable. Okay, maybe you need a custom, or you have a complex problem. So yeah, I'd encourage them. I think, try it out. If you think it looks dynamically enough and they're complaining of pain, that's an automatic too for me.
You mentioned offloading metatarsal stress fractures upwards of 16 weeks. Would you take the same approach for a midfoot stress fracture like you would?
Yeah, I think the midfoot gets even more complicated. Like those naviculars and cuboids, they're taking a lot of pressure through those areas. And when I mean treat them, they're not offloaded for 16 weeks. I'm just telling you it's taking them that long to get better. So once I kind of get you offloaded, even within 2-3 weeks, your fracture area is gonna feel a lot better. But you don't want to walk on it too early. You gotta get that bone set. Like you saw the ligament healing. Bone takes even a little bit longer, but when it does heal, it heals well. So that's why, you know, fractures were often 6 to 8 weeks. Same kind of deal on that, yeah.
This fad is, I think, kind of fading, but, you know, if a patient asks you about the barefoot, like barefoot running versus running
Yeah.
shoes, what do you like?
Yeah, so the question is about barefoot running, if that's a good idea. You know, definitely if someone has a higher arched foot, that's the right foot shape to do it easily. It's not to say someone who's got flat feet can't. And it's really what's the purpose of it? Like if they really love running and want that feeling, it's not dangerous or anything like that, but it's not like everyone needs to. And you know, a lot of the science was like barefoot running makes you not hit the heel so hard and land so heavy. Like if you had no shoes and it would hurt if you landed really hard, you're probably gonna run very carefully, right? So people use better technique with that. But in terms of the fad, yeah, I would say people have moved away from all minimal and that's the right way to run. It's not that everyone needs to run like that. Thank you.
Touch on metatarsalgia, and then how often do you change orthotics?
Okay, so metatarsalgia. Metatarsalgia can be kind of tricky because like you're talking about that overload, like I said about the second metatarsal head can be too much or, you know, obviously either the bones are getting overloaded or the second metatarsal is getting overloaded and the soft tissues are getting irritated. You know, a lot of times they're older patients and the fat pads are starting to thin down. You know, definitely good footwear, good protection, because there's not many things that the surgeons can do or anything like that unless it's extreme. Like in a second metatarsal head thing, they might actually shorten the ray. They might take it down so that's no longer your main pressure point. And then in terms of the orthotics, they can last several years and stuff like that. I think it's all dependent on the material that they're made out of. Some of the softer materials like cork and things like that, they might have a lower longevity, maybe like 3 to 5 years, whereas like those hard plastic ones, like I was wearing those for a while. Now, I think talk to a professional orthotist, they might have another opinion on how long hard things are, but your foot changes over time, right? Your dynamic. So is it working? Is it not working? Definitely if it's not working and it's been a few years, it might be worth adjusting them. And they always need to be resurfaced and everything gets all gross and stuff like that. So you need to maintain them.
The metatarsalgia, some of the patients who are sportsmen that get diagnosed with that, is it usually all the metatarsals that are inflamed or it's just the second?
You know, I think it's one of those catch-all like knee pain or like shin splits. It's metatarsalgia is just any kind of pain over the rays. So I think you really got to be a little more specific when they're not getting better. Try to find the diagnosis and stuff. Yeah.
All right, guys.
All right.
Out of time for Dr. Lou.
Thanks.
But thank you.